Hello, I'm Dr. Israel Barken, the Medical Director of the Prostate Cancer Research and Education Foundation. Today we are going to discuss the guidelines for castration-resistant prostate cancer. This was established by the American Urological Association and was presented at the latest American Urological Association meeting 2013. So let's go now to the castration-resistant prostate cancer guidelines. Prior to the discussion of the guidelines for castration-resistant prostate cancer, I would like to explain and bring up the point that there are multiple medications that were approved by the FDA, and now the dilemma is for physicians to try to sort out which medication to give first or in what combination. So before we talk about the guidelines, let's review and look at what new medication recently were approved by the FDA or are still under study. The source of the information about the list of medication is taken from PEC, the Prostate Cancer Communication Newsletter, and it's from their Volume 29, Number 2, June 2013. And in this issue we find a list of new approved medication and treatment for prostate cancer. Let's look at them, and what's quite impressive is the number of medication and treatments that were approved, and that creates indeed a dilemma for physicians to know what to use first and in what combination, and that's what prompted the issuing of guidelines from the American Urological Association. Let's go now and look at the table of the new treatments. So first, let's look not at a drug, but at a radioisotope Radium-223. You see, they gave it a name, Xofigo, and it's by Bayer. It was approved for castration-resistant prostate cancer. The route is by IV, and it received FDA approval on May 15, 2013. The next medication, Xtandi enzalutamide, it's for chemotherapy-naive, progressive metastatic disease. Phase 3 trial ends in the second half of 2014. It's oral, and it was approved for patients who have tried and failed chemotherapy. Then the next medication we see is Zytiga, abiraterone, for newly diagnosed chemotherapy and androgen deprivation therapy naive metastatic disease. Phase 3 trial ends in 2013. It's already approved for patients who have tried and failed androgen deprivation therapy. Then we have testosterone synthesis inhibitor. We have the TAK-700, which you see here was pre and post chemotherapy castration resistant. Will likely be used in combination with prednisone, and it's still phase 3 trial ends third quarter of 2013, very soon. Then we have another variant here of TOK-001, also for chemotherapy-naive castration-resistant, and its phase 2 clinical trials may be required the use of prednisone. Androgen receptor blockers, we have the ARN-509, treatment-naive and treatment-experienced metastatic and non-metastatic castration-resistant. It's in phase 2 trial and in second quarter of 2013. Then we have the ODM-201, for castration-resistant phase 2 study. And then we see the cabozantinib, which is Excellis, is for metastatic resistant disease. Phase 3 trials end second quarter of 2014. It's already approved for progressive metastatic medullary thyroid cancer. Prostvac, which moved to phase 3 study as a new type of immune therapy, and taquinimab is also for asymptomatic or mildly asymptomatic metastatic disease, and it's in phase 3 study. So you see there are treatments that were approved already by the FDA and treatments that are going to probably be approved and are in very advanced stages of development and ready for approval by the FDA. And that's why creating guidelines is very, very important. What's important to understand about guidelines is that the Professional Association of the American Urological Association, they claim that this is not mandatory for doctors to follow, although there is a lot of pressure on doctors to follow this recommendation that, as you will see, are quite vague. But there are two reasons why doctors have to follow guidelines. One of them, you are more protected from malpractice if you follow guidelines of your association. And number two, there is a danger there that insurance companies will not cover medications that were not approved by the guidelines. So that's really a dilemma. I still want to hope that patient and doctor will be able to decide for themselves what treatment is appropriate for them. So let's go now and look at the guidelines themselves. So here is a summary of the guidelines of the AUA, the American Urological Association, in regards to castration-resistant disease. You see there's a nice flow chart that we could go over. But when you look at the flow chart, we already see that what determines what to do with the patient are the following conditions. One, is the patient metastatic or non-metastatic? Two, is the patient before or after chemotherapy, the Taxotere? Three, what is the performance status of the patient? And four, very important, is the patient symptomatic or not symptomatic of his disease? So they created here 6 index patient examples, which we will go after each index patient number here, and we'll try to go over what are the recommendations to consider. So let's go now to index patient 1. As I said, they have 4 factors to consider what to do. So whether you are metastatic or non-metastatic, index patient 1 is a patient who is non-metastatic at the time that he becomes castration-resistant. So their recommendations are that clinicians should recommend observation with continued androgen deprivation. Clinician may offer treatment with first-generation anti-androgen, flutamide, baclutamide, and alutamide, or first-generation androgen synthesis inhibitor like ketoconazole or nizarole to select patients unwilling to accept observation. So those that do not want observation, they could get the nizarole. It says here in red box, clinicians should not offer systemic chemotherapy or immunotherapy outside of the context of clinical trial. And this is a very important point, that some patients, certain treatments are not available to them unless they join a clinical study. Let's go now to index patient 2. Here you see we talked about the non-metastatic. Now we move to metastatic castration-resistant. And the group of metastatic castration-resistant is divided into 2. No prior chemotherapy, Taxotere, or having prior chemotherapy, the Taxotere. So let's look now at the no prior chemotherapy. They divide them again into 2. Those that are asymptomatic or minimally symptomatic, and those that are symptomatic. So let's go now to those that are symptomatic and look at index patient 2. Clinicians should offer abiraterone, prednisone, Taxotere, systemic chemotherapy, or immune therapy, the Provenge. Clinician may offer third-generation anti-androgen therapy like ketoconazole, plus steroids, or observation for patients who do not want or cannot have one of the previously listed standard treatment. So this is for patients that are without chemotherapy. They may get chemotherapy now, but are asymptomatic or minimally symptomatic. Let's move now and look at the patients that are symptomatic. The index patient number 3. The index patient number 3, the one that is symptomatic already, we divide between good performance or poor performance. So on index patient number 3, clinicians should offer chemotherapy, because if they already are symptomatic and they could tolerate chemotherapy, they should be offered chemotherapy. They could tolerate it because they have good performance status. Clinicians may offer abiraterone and prednisone. They may offer nizarole, mitoxantrone, or radionuclide therapy. Remember we mentioned the radium-223 to patients who do not want or cannot have any of the previous listed therapies before. It says here clinicians should not offer treatment with either MCT, estramustin, or immune therapy because they already are symptomatic, and that's why they recommend not to give the immune therapy. The immune therapy is given to patient earlier situation. So let's go now to index patient number 4. That's a patient who is symptomatic, but instead of having good performance status, he has poor performance status. So index patient number 4, clinician may offer treatment with abiraterone. Clinician may offer treatment with ketoconazole to patients who are unable or unwilling to receive abiraterone. Clinician may offer chemotherapy in select cases. When you have poor performance status, then you are more selective whether to expose them to a toxic chemotherapy. Clinician should not offer immune therapy. Let's go now to patients, the index patient number 5. Index patient number 5 is somebody who had metastatic castration-resistant disease but already had prior chemotherapy but has good performance status. We'll see what happens when he has good performance status, that's patient number 5, and poor performance status will be patient number 6. So let's see what the recommendations are for somebody with metastatic castration-resistant, had prior chemotherapy, and had good performance status. Clinicians should offer treatment with abiraterone, cabazitaxel, which is a second-line chemotherapy, or enzalutamide, which is the Xtandi. If the patient received abiraterone prior to Taxotere, cabazitaxel or enzalutamide should be offered. Clinician may offer also nizarole and steroids if one of the previously listed standard treatments is unavailable. Clinician may offer treatment with Taxotere again if they benefited from Taxotere first time. Let's go now to index patient number 6, who is a patient who had metastatic castration-resistant prostate cancer, had prior Taxotere, but has poor performance status. Clinician should offer palliative care. Clinician may offer treatment with abiraterone, enzalutamide, ketoconazole, or radionuclide therapy for disease in the bone. Clinician should not offer systemic chemotherapy or immune therapy in this patient who are really in poor performance status after they failed chemotherapy. What is interesting, that part of the guideline for castration-resistant, they also bring the issue of guideline statement for bone health and for all index patients that were mentioned. What they say is that clinicians should offer preventive treatment, supplemental calcium and vitamin D for fracture and skeletal related events to castration-resistant prostate cancer patients. They also say the clinician may choose either denosumab or zoledronic acid when selecting a preventive treatment for skeletal treated events for castration-resistant prostate cancer patients with bony metastases. These include all patients with castration-resistant. You have to pay attention now to the bones because that's the area where the disease will strike now, and you want to avoid morbidity and suffering of the patient from metastatic disease in the bone. Thank you very much for listening. If you have any more questions, please don't hesitate to call our foundation at 619-906-4700 or write to us at info@pcref.org. Thank you for listening. Stay well, stay informed, and have fun. Goodbye.